everyone, I'm Siddhi Pawar. Welcome back to my channel. Well, it's been a long time last I have been here, but I was busy like I had second term exam, then I had Vedan 2021. After that I had prelims and then the Respira 2021 in the BG Government Medical College Pune in which I'm in the second year. And now finally the universities have been postponed by MUHS to the 3rd March. I've got some free time to go through the second year subjects which I have literally not done for last 1 month because of the events. But I thought why not share with you all and start the revision sessions. So here I am starting with pathology, respiratory system, the pneumonias. Okay. So definition. Pneumonia is defined as the acute inflammation of the lung parenchyma distal to the terminal bronchioles. Now, distal to the terminal bronchiole, it will be consisting of the respiratory bronchiole, alveolar ducts, alveolar sacs, and alveoli. Now, in this, if you see the competencies according to the batch 2019 and onwards people, we have to follow three or we have to study the three things that is etiopathogenesis, morphology, and complications. So, we will be revising these in this session. First is etiopathogenesis. So, etiology, basically the microbes. Now, the microorganisms gain entry into the lungs by one of the following four routes. The four routes are inhalation of the microbes present in the air. Second is the aspiration of the organisms from the nasopharynx or the oropharynx. Then there can be the direct spread from the adjoining site of infection or the hematogenous spread from a distant focus of infection. Now, the normal lung is free of the bacteria because of presence of number of lung defense mechanisms at different levels. Like you have the nasopharyngeal filtering action or the mucociliary action of the lower respiratory airways, then the presence of phagocytosing alveolar macrophages and the immunoglobulins. But the failure of these defense mechanisms and the presence of certain other predisposing factors result in the pneumonias. Now, these conditions where we will find the pneumonias, where we can find the certain predisposing factors, these conditions are like enumerated here. First is the altered consciousness. Then the oropharyngeal contents may be aspirated in the states causing unconsciousness, like in coma, cranial trauma, seizures, cerebrovascular accidents, drug overdose, alcoholism, etc. Second is depressed cough and glottic reflexes. Now, depression of the effective cough may allow aspiration of the gastric contents, like in old age, in pain from trauma or thoracoabdominal surgery, neuromuscular disease, or the weakness due to malnutrition, kyphoscoliosis, severe obstructive pulmonary diseases, endotracheal intubation, and tracheostomy. Third is the impaired mucociliary transport. The normal protection offered by the mucus covered ciliated epithelium in the airways from the larynx to the terminal bronchioles is impaired or destroyed in many conditions, favoring passage of the bacteria into the lung parenchyma. These conditions are like the cigarette smoking, viral respiratory infections, or inhalation of hot or corrosive gases, and old age. Fourth is impaired alveolar macrophage function. Pneumonias may occur when the alveolar macrophage function is impaired, like by the cigarette smoke, hypoxia, starvation, anemia, pulmonary edema, and viral respiratory infections. Endobronchial obstruction. The effective clearance mechanism is interfered in endobronchial obstruction from tumor, foreign body, cystic fibrosis, and chronic bronchitis. And in immunocompromised states, disorders of lymphocytes, including congenital or acquired immunodeficiencies like AIDS or some immunosuppressive therapy, and granulocyte abnormalities, these all may predispose to the pneumonia. Moving on to the classification of the pneumonia. Now, on the basis of the anatomic region of the lung parenchyma involved, the pneumonias are traditionally classified into three main types, that is lobar pneumonia, bronchopneumonia or the lobular pneumonia, and the interstitial pneumonia. Based on the clinical settings in which the infection occurred, pneumonias are classified as community acquired pneumonia, healthcare associated pneumonia, which will include the hospital acquired pneumonia, and the ventilator associated pneumonia. And lastly, based on the etiology and pathogenesis, pneumonias are classified as bacterial pneumonia, viral pneumonia, or pneumonias from other etiologies. So, first we will study mainly the bacterial pneumonia. Now, bacterial infection of the lung parenchyma is the most common cause of pneumonia or consolidation of one or both the lungs. There are actually two types of pneumonia, that is Lobar pneumonia and the bronchopulmonary pneumonia, or bronchopneumonia basically, mainly. Now, that is lobular pneumonia also. Apart from this, there is another type distinguished by some workers, which is separately known as confluent pneumonia, which combines the features of both lobar and the bronchopneumonia. So we'll be studying the lobar pneumonia first, in which we will see the what's actually lobar pneumonia. So lobar pneumonia is an acute bacterial infection of a part of a lobe, the entire lobe, or even two lobes of one or both the lungs. Etiology. Based on the etiologic microbial agents causing the lobar pneumonia, there are different types of the lobar pneumonia. Like the first is Streptococcus pneumoniae causing pneumococcal pneumonia. More than 90% of lobar pneumonias are caused by this. Next is Staphylococcal pneumonia, and that is obviously caused by the Staphylococcus aureus. Then there is Streptococcal pneumonia caused by the other beta hemolytic streptococci. Lastly, we have the pneumonia by the gram-negative aerobic bacteria, and these bacteria are the Haemophilus influenzae, then Klebsiella pneumoniae, Pseudomonas proteus, or E. coli. The morphology of the lobar pneumonia. Now, in lobar pneumonia, as the name suggests, part of a lobe, a whole lobe, or two lobes are involved, and sometimes bilaterally. The lower lobes are affected most commonly. Now, Lanick's original description divides the lobar pneumonia into four sequential pathological phases, which is stage of congestion, that is initial phase, then the red hepatization, that is early consolidation, then you have gray hepatization, that is late consolidation, and the resolution. Let's see the stages clearly. So, the stage of congestion or the initial phase, it represents the early acute inflammatory response to the bacterial infection that lasts for 1 to 2 days. So, grossly, if you see, the affected lobe is enlarged and heavy. There is dark red, they are dark red and congested. Now, the cut surface exudes the blood stained frothy fluid. Histologically, typical features of acute inflammatory response to the organisms are seen. Like you can see the dilatation and the congestion of the arteries or capillaries in the alveolar valves. Then you have pain, eosinophilic edema, fluid in the air spaces, a few red cells and neutrophils in the intraalveolar fluid, and there are numerous bacteria demonstrated in the alveolar fluid by gram staining. Next is red hepatization, that is the early consolidation. Now, this phase lasts for 2 to 4 days, and the term hepatization in the pneumonia refers to the liver like consistency of the affected lobe on the cut surface. So, if you see the grossly, then the affected lobe is red, firm, and consolidated. The cut surface appears to be airless, red, pink, dry, and granular, and it has liver like consistency. Then you also have serofibrinous pleurisy accompanied with the red hepatization. Histologically, you will see the following features. The edema fluid of the preceding stage is replaced by the strands of fibrin. There is marked cellular exudate of the neutrophils and extravasation of the red cells. Many neutrophils show ingested bacteria. The alveolar septa are less prominent than in the first stage due to the cellular exudation. Next is gray hepatization, that is the late consolidation. Now, this phase lasts for 4 to 8 days only. The gray hepatization, if you see the grossly, then the affected lobe is firm and heavy. The cut surface is dry, granular, and gray in appearance with liver like consistency. The change in color from red to gray begins at the hilum and spreads towards the periphery. Fibrinous pleurisy is prominent. Histologically, the fibrin strands are dense and more numerous. The cellular exudate of the neutrophils is reduced due to the disintegration of many inflammatory cells as evidenced by their pycnotic nuclei. Red cells are also fever, so the macrophages begin to appear in the exudate. The cellular exudate is often separated from the septal walls by a thin clear space, and the organisms are less numerous and appear as degenerated forms. Lastly, you have the resolution, and this stage begins by the 8th or 9th day, and if there is no chemotherapy administered, and it is completed in 1 to 3 weeks actually. However, if the antibiotic therapy is induced, then the resolution will start by 3rd day itself. Resolution obviously proceeds in a progressive manner, and grossly, the previously solid fibrinous constituent is liquefied by enzymatic action, eventually restoring the normal aeration in the affected lobe. The process of softening begins centrally and spread to the periphery. So the cut surface is gray red or dirty brown, and frothy yellow creamy fluid can be expressed in pressing. You can see the resolving pleurisy. Now, after this, the pleural reaction may also show resolution but may undergo organization, leading to fibrous obliteration of the pleural cavity. Histologically, you can see the macrophages. Now, they are more in number, they are numerous, they are the predominant cells in the alveolar spaces, while neutrophils diminish in number. Many of the macrophages contain the engulfed neutrophils and the debris. Granular and fragmented strands of fibrin in the alveolar spaces are seen due to progressive enzymatic digestion. The alveolar capillaries are engorged. There is progressive removal of the fluid content as well as the cellular exudate from the air spaces, partly by expectoration but mainly by lymphatics, resulting in restoration of the normal lung parenchyma with aeration. And hence the resolution is complete. So these are the 4 phases: stage of congestion, red hepatization, gray hepatization, and the resolution. Moving on to the complications of the pneumonia. Now, since the advent of the antibiotics, serious complications of lobar pneumonia are uncommon. However, they may develop in neglected patients and in patients with impaired immunological defenses. So, what are these complications? First is organization, as you've already studied. In the stage of the resolution, last stage, the pleural reaction may also show resolution, but it can sometimes undergo the organization. And what will happen? It will lead to the fibrous obliteration of the pleural cavity. And this happens in 3% of cases actually. And this type of post-pneumonitic fibrosis is called as carnification. Then second complication is pleural effusion. 5% of people have this. They develop the inflammation of the pleura with effusion, and usually it resolves but sometimes may undergo organization, and with fibrinous adhesions between the visceral and parietal pleura, again that is your carnification. Then you have empyema. Less than 1% of treated cases of lobar pneumonia develop the encysted pus in the pleural cavity, termed the empyema. Lung abscess, again a rare complication. Then you have metastatic infection. Occasionally, infection in the lung or pleural cavity in lobar pneumonia may extend to the pericardium and heart, causing the purulent pericarditis, bacterial endocarditis, and myocarditis. Other forms of this metastatic infection, like rarely it occurs, but it can be, that is your otitis media, mastoiditis, then you have meningitis, or you have brain abscesses, or any purulent arthritis. Then the clinical features. Okay, this is also important to diagnose the pneumonia, Lobar pneumonia specifically. So, if you see classically, the onset of the Lobar pneumonia is sudden. The major symptoms are the shaking, chills, or the fever, malaise with pleuritic chest pain. Then you have dyspnea, then cough with expectoration, which the expectoration could be mucoid, then purulent, or even bloody. Some common physical findings will include fever, then tachycardia and tachypnea, and sometimes cyanosis if the patient is severely hypoxemic. Now, there is generally a marked neutrophilic leukocytosis. So, blood cultures are positive in about 30% of cases, and the chest radiograph will show you the consolidation. So, this is it for lobar pneumonia. Moving on to the bronchopneumonia. Now, as you can see here in the picture, the lobar pneumonia and the broncholobular pneumonia. Let's see it. The etiology. Now, first, bronchopneumonia or the lobular pneumonia is the infection of the terminal bronchioles that extends into the surrounding alveoli, resulting in patchy consolidation of the lung. Now, this condition is particularly frequent at the extremes of the life as a terminal event in chronic debilitating debilitating diseases and as a secondary infection following the viral respiratory infection. Now, etiology, as I've already said, there is Staphylococci, Streptococci, Pneumococci, Klebsiella pneumoniae, then you have Haemophilus influenzae, gram-negative bacilli like Pseudomonas or some coliform bacteria. Then the morphology. Grossly, if you see, grossly you will see the patchy areas of red or grey consolidation. Now, this bronchopneumonia, it usually is affecting one or more lobes, frequently found bilaterally, but more often involving the lower zones of the lungs due to gravitation of the secretions. On cut surface, you will see there are patchy, consolidated lesions, and these lesions are dry, granular, firm, red or gray. Then you have the slightly elevated lesions, and they are often centered around the bronchioles, around a bronchiole. Now, these patchy areas are best picked up if you pass the fingertips over the cut surface. Histologically, you can see the acute bronchiolitis. Then there is suppurative exudate, which will consist mainly of the neutrophils in the peribronchiolar alveoli. Then you have thickening of the alveolar septa by congested capillaries and leukocytic infiltration, and the less involved alveoli may contain the edema fluid. Then comes the complication. Now, complication of the lobar pneumonia. Again, they are somewhat similar to the bronchopneumonia and lobar pneumonia. The same complications are seen here. However, complete resolution of bronchopneumonia is uncommon. There is generally some type of destruction of these bronchioles resulting in foci of bronchial fibrosis, and this may eventually cause the bronchiectasis. Then clinical features. Now, the patients of bronchopneumonia are generally infants or the elderly patients, and there may be history of some preceding bedridden illness or chronic debility or the aspiration of the gastric contents or the upper respiratory infection. And for initial 2 to 3 days, there are the features of the acute bronchitis, but subsequently these signs and symptoms will be similar to that of the lobar pneumonia. So then the blood will usually show the neutrophilic leukocytosis, and the chest radiograph will show mottled focal opacities in both the lungs, usually in the lower zones. So this is it for bronchopneumonia. So this is the bacterial pneumonia. There is viral and mycoplasmal pneumonia also called as primary atypical pneumonia. Viral and mycoplasmal pneumonia is characterized by the patchy inflammatory changes, largely confined to the interstitial tissue of the lungs without any alveolar exudate. Other terms are the interstitial pneumonitis. Now, etiology, if we see, the Mycoplasma pneumonia, obviously the name. Then you have other viruses, mainly the respiratory syncytial virus, RSV. Then you have influenza, parainfluenza viruses, adenoviruses, rhinoviruses, Coxsackie viruses, and cytomegaloviruses. Apart from that, occasionally you have chlamydia or Coxiella causing this interstitial pneumonitis. Now, in most of the cases, the infection remains confined to the upper respiratory tract, presenting as common cold. However, it may extend lower down and then involve the interstitium of the lung. Morphological features. So, grossly, if you see, depending upon the severity of the infection, the involvement can be patchy to massive, and widespread consolidation of one or both the lungs can be seen. The lungs are heavy, congested, and subcrepitant. The section surface of the lung will have some exudate of the frothy or bloody fluid. Then the pleural reaction is usually infrequent and mild. Histologically, the hallmark of the viral pneumonias is the interstitial nature of the inflammatory reaction. So, interstitial inflammation, this is the thickening of the alveolar walls due to congestion, edema, and mononuclear inflammatory infiltrate comprised of the lymphocytes, macrophages, and some plasma cells. Apart from this, you can see necrotizing bronchiolitis, then reactive changes and alveolar changes in this. Complication, if you see, the most of the cases of the interstitial pneumonitis recover completely. Major complication, if any, is then that is the superimposed bacterial infection and its complications. Clinical features. Now, majority of these cases initially will have upper respiratory symptoms with the fever, headache, and muscle aches. And few days later, they will have dry, hacking, non-productive cough with the retrosternal burning, and it might appear due to tracheitis or bronchitis. Blood film will obviously have the neutrophilic leukocytosis, and the chest radiograph will show patchy or diffuse consolidation. Lastly, last second, we have the fungal infection. Fungal pneumonias, these are more common than TB in the US, whereas in India, TB is more common. Here you have pneumocystis pneumonia. Again, it is pneumocystis, it causes opportunistic fungal infection. Pneumocystis jirovecii, it causes pneumonia by inhalation of the organisms in neonates and immunosuppressed people. So, morphologically, the affected parts of the lung are consolidated, dry, and gray. And microscopically, if you see the interstitial pneumonitis, there is thickening and mononuclear infiltration of the alveolar wall seen there. Then you have alveolar lamina, which contain the pink frothy fluid having the organisms. And under the methymine silver stain, you can see there are some oval concentric cysts there. And near the cyst, there are surrounding the cyst, there are numerous tiny black dots, and these are P. jerovicae actually, that is your pneumocystis jerovicae, and there is no significant inflammatory exudate in the air spaces. Clinical features: rapid onset of the dyspnea, tachycardia, cyanosis, and non-productive cough. And then lastly is the non-infective pneumonias, which include aspiration pneumonia or inhalation pneumonia, then the hypostatic pneumonia and the lipid pneumonia. And here we come to the end of the pneumonia revision session. Thank you and see you in the next session.